Hello, everyone. Are we audible? Please mention in the comments. Yes. Thank you. We'll start at 6:30. 2 more minutes to go. That's it. Thank you. Dr. Swati, we can start now.
Hello everyone, I'm Dr. Swati Prabhu. I'm working in Government Medical College, Chandigarh, and we welcome you all to 7th KCIAPM PAT webinar. So we request you all to share the information with your colleagues, the postgraduates, students, and encourage them to watch this and also participate in this live webinar. We also request you to, set the YouTube resolution at 480 or 720 pixel, so that you can get the clear images. And feel free to post any queries, any questions that you have in the comment section, and we'll take all these questions at the end of the webinar. Over to Dr. Aditya to introduce our speaker.
Hello, everyone. I'm Dr. Aditya Agnihotri, Assistant Professor at STM College of Medical Sciences and Hospital, Dharwad. I'm very proud to introduce our today's speaker, Dr. Raghavendra Pillappa. That's because he is also one of the alumni of KIMS Hubballi, from where I come from. So he's a very proud alumnus of KIMS Hubballi, and in fact, he got a RGHS gold medal for pathology during his post-graduation. After that, he worked in Bangalore for some time before moving to US for his APCP residency. After that, he pursued fellowship in general surgical pathology and pulmonary pathology, both from Mayo Clinic in Rochester, Minnesota. So currently, he's based in Virginia and is working as a full-time assistant professor at Virginia Commonwealth University. And he specializes in pulmonary pathology and breast pathology. So,
thank you, Aditya. Hello, everyone. Yeah, my name is Raghav Pillappa, like Aditya said. I'm a pulmonary pathologist, but also do surgical pathology. I sign out breast, heart, and also sometimes I also sign out GYN. And again, I'm very excited today that KCIAPM has invited me for this presentation, and also thank Aditya and Swati for joining us today and introducing for the kind words and everything. So I'm excited.
now, Dr. Swati will introduce us to the topic, and then we'll go ahead with the presentation straight away.
So today's topic will be diagnostic approach of lung neoplasms on small biopsies. So as we know that lung cancer is one of the most common cancer-related deaths, and at the same time we get a lot of lung biopsies, and diagnosing them accurately, subtyping them is very essential for therapeutic implications. So we have Dr. Raghavendra Pillappa to carry on the presentation.
Thank you, Swati, for that introduction. Let me share the screen. Let me share the PowerPoint. Can you guys see the PowerPoint?
Yes, we can see it. Please go ahead.
Great. So my topic for today is obviously lung neoplasms in small biopsy. So I thought of this approach because nowadays, as you know, nothing to disclose the financial disclosures as far as that side is important for us to disclose. So lung cancer is important to be diagnosed at an early stage. So that's why I chose this topic. So for any presentation, we need to have good learning objectives. So the learning objectives for today's presentation is to identify the different morphological features, patterns of lung neoplasms in a needle core biopsy specimens. So I'm going to give a lot of examples for needle core biopsy specimens. And also in the process, we're going to recognize the challenges during histological and immunohistochemical analysis. And then also the other important is targetable therapy. So to summarize the importance of molecular testing in lung cancer, so that's going to be my 3 learning objectives for today. In my outline, I'm going to discuss currently accepted terminologies, what we can use on this lung core biopsies, then diagnostic criteria, special circumstances, which I'm going to tell you as we go along with this presentation, then finally summarize with molecular testing. Why is there a need for lung biopsy? Obviously, to detect the lung cancer at an early stage to reduce the mortality. But more important would be specimen adequacy for ancillary tests to detect growing number of targetable mutations. As you must be seeing, FDA has got so many approved drugs for targetable mutations in lung cancers. So our oncologists and surgeons, especially, they want us to identify any targetable mutations when we diagnose lung cancer on our biopsy. So previously, as pathologists, we were like diagnosing cancers, but now our role has increased or expanded in such that we are also responsible for guiding the treatment. And if there's any targetable mutations, it's important that we identify those by various modes of testing, be it next generation sequencing or FISH or even immunohistochemistry. So I'm going to briefly touch upon those aspects as well. And in our setting, in my institution at VCU, Richmond, Virginia, we generally do fine needle aspiration along with EBUS and needle core biopsies all at the same time. So, but in today's presentation, I'm going to show you needle core biopsy specimens and not cytology smears because I'm not a cytopathologist. So, but I will be showing the relevant points for the needle core biopsies. As far as the lung cancers are concerned, the survival rate, it has got up to 25% mortality and 5-year survival rate relative to pancreatic cancer. It stands second. It's obviously better with a clinical stage 1A with 92% 5-year survival rate, while clinical stage 2B it is 53%. So obviously early stage is important or critical for us to identify the lung cancer so that we can improve on the survival rates. So according to the updated NCCN guidelines, tumor size feasible for biopsies at least 6 millimeters for subsolid nodules and 8 millimeters for solid nodules. For central lesions, ultrasound-guided transbronchial biopsy is used for both diagnosis and staging, while for peripheral lesions, CT-guided transthoracic biopsy is a recommended modality. So here's the first example. So I'll be showing a needle core biopsy from a 69-year-old man with a lingular nodule. So as you can see in this photomicrograph, there is enough tissue, and then you can see this glandular structures or glandular growth pattern. You'll also see this ovulated lung parenchyma, pigmented macrophages in the background. Higher power of that, you see this tumor cells forming glandular structures. And there is some desmoplastic reaction, not much, but there are irregular sized glands with lumens and their cells in stratification. So there is no problem with diagnosis in this core biopsy. Definitely because of the glandular differentiation, we are obviously thinking of adenocarcinoma. And this tumor was TTF1 positive and P40 negative. So with that supportive immunohistochemical stains, we can definitely call this as adenocarcinoma of lung origin. So let's look at the features sufficient for diagnosis in needle core biopsies. So if you have a definite gland formation or intracytoplasmic mucin vacuoles, then that's sufficient for diagnosis on H&E for adenocarcinoma. Again, minimal immunohistochemical stains is recommended so to preserve the tissue. And most of the times TTF1 and P40, that's all many places do. And in my institution also, we try with TTF1, P40. And then if that doesn't work, then we expand the panel. Otherwise, we just restrict TTF1 and P40. And again, if TTF1 is positive, sometimes you have a cocktail stain where you combine TTF1 and napsin. Like in my institution, we have this combination stain. TTF1 or napsin and positivity with a solid lung mass, like in this patient, is sufficient to call it as lung primary. So you might see different histological growth patterns in these biopsies. But if you see a lipidic growth pattern, like what you see in this small image on the right side, where the left half of the slide you see this alveolar architecture, and the right half you see this tumor cells lining this alveolar spaces, as if similar to if you can imagine butterfly sitting on the fence kind of appearance. So then that's called lipidic growth pattern. And subclassification by predominant pattern, histologic pattern, is not required on a needle core biopsy. But you can mention the histologic growth pattern in the comment. And most often we get this question, can we differentiate the entities, atypical adenomatous hyperplasia versus adenocarcinoma in situ versus minimally invasive adenocarcinoma? I would definitely not attempt to differentiate that on a needle core biopsy because the criteria are different. And you need to look at the resection to make sure to see the entire lesion before making a distinction between these entities. For example, the definition or the differences between AAH and AIS. You can see the size of AAH is small, 0.5 or less than or equal to that. Larger, 0.5 equal, more than 0.5 to 3 centimeters. That's adenocarcinoma in situ. But the common factor here is pure lipidic growth pattern. While you might see some gaps between the cells in atypical adenomatous hyperplasia, but otherwise you may not see it in adenocarcinoma in situ. And both are TTF1 positive, so not helpful. And the other entity is minimally invasive adenocarcinoma, which I did not bring in this table. And the only difference here is the size of the tumor is still less than 3 centimeters, but the invasive area is less than or equal to 5 millimeters. Again, what do we call invasive area? Any pattern other than lipidic growth pattern, like acinar, papillary, solid, or cribriform. So any other growth patterns other than lepidic is considered as invasive growth pattern. And then your regular classic desmoplastic reaction with infiltrating tumor cells. So if you see those areas amounting to 0.5 centimeters and less, and the entire tumor is 3 centimeters, then you consider minimally invasive carcinoma, adenocarcinoma. So with such difficulties, it's definitely the differentiation between these entities are reserved for an excision specimen or resection specimen. So not recommended to differentiate this or mention this in a needle core biopsy. That's the first point. So if you see lepidic growth pattern, then how do you sign this out? You can say adenocarcinoma with lepidic pattern, with the above comment saying that the diagnosis of adenocarcinoma in situ versus minimally invasive adenocarcinoma is reserved for a resection specimen. So this happens only if there's lepidic growth pattern in biopsy. But if you see other patterns in the biopsy, obviously that's an invasive adenocarcinoma, which you can easily come to the diagnosis. So some of the challenges with immunohistochemistry for adenocarcinoma, or generally, when you do this minimal immunohistochemical stains. So P63 is another marker for squamous cell carcinoma. P40 obviously is a marker, as you know. So if TTF1, P63, and P40 are co-expressed in the same tumor cells, then the terminology preferred is non-small cell carcinoma favor adenocarcinoma, because the TTF1 positivity trumps P63 and P40 positivity. Again, you have to remember that adenocarcinomas can be P63, P40 positive, but there's a low frequency of TTF1 positivity in squamous cell carcinoma. So keep that in mind, TTF1 trumps other stains. But if you see TTF1 and P63 are P40 positive in different tumor cell population, that means you have two distinctive tumor cell population, which looks different on morphology on H&E stain. And immunohistochemically, you have these two different populations marking differently. One population TTF1 positive, the other one P40 positive. Then you can mention in the biopsy that there are components of adenocarcinoma and squamous cell carcinoma. Again, you can raise a concern for adenosquamous carcinoma, but the diagnosis is reserved on a resection specimen. But you can definitely tell them that it's a concern for that, and you have both the components, adenocarcinoma and squamous cell carcinoma components. But see the difference, the evaluation of immunohistochemical stains is very important as to the location of the tumor cells. So it's important that you look at this immunostains, especially TTF1 is a nuclear stain, similarly P42. So make sure you see the stain in the tumor cells, not in the basal cells or not in the entrapped pneumocytes. Again, that's another pitfall, and it might be challenging sometimes to differentiate. But remember these points that if you see them in both the cells, TTF1 is positive and that trumps other stains, stain positivity, then you favor adenocarcinoma. If you see in different distinctive tumor cell populations, then adenosquamous is a concern. So obviously that is the diagnosis is reserved on a resection specimen. One more example, needle core biopsy of right lower lobe. This patient, 70-year-old, had a history of lung adenocarcinoma, status post resection, now has a new right lower lobe mass along the suture line. Good amounts of needle core, and you can definitely see some glandular areas here in the inflammatory rich background. On higher magnification, you can see the solidness of cells, vaguely glandular, but pretty much solidness. Some might look like having some clear cell cytoplasm, but otherwise looks like some of them also have some mucinous kind of appearance into them. But otherwise, it's sufficient to call it as polypositive for malignancy, and because there are some glandular structures, you might think of adenocarcinoma as well. So higher magnification, you can see some mucin vacuoles here, mucin cytoplasmic vacuoles as well. But otherwise, it shows some solid growth pattern, but also has that irregular glandular kind of appearance. So obviously we call this as adenocarcinoma, and it was the suture line, so it was consistent with recurrent lung adenocarcinoma. So you have to understand that if a patient with a history of adenocarcinoma has got an adenocarcinoma at the suture line, you can call that recurrent. But if you have it in a different lobe, obviously, then that would be a T4 lesion on the pathologic staging. But if you have it in a contralateral lobe, then that is accounted as metastasis. So remember that point. And we also compared this slide to the previous tumor resection of the patient, and it showed similar morphology. Again, that's always a gold standard we use. Comparing the patient's previous slides, it's like no cost. Means if you're running immunohistochemical stains, it costs you money. But sometimes you just comparing with the patient's previous slides would give you the answer. You might the current tumor cells would look similar to the patient's previous. Then you get off the hook saying that it's the same tumor. But if it looks different, you might think of a new primary or a new cancer. So it's a low-cost option. So always remember that. Another example here, needle core. You got sufficient sample here, but you see these glandular structures with mucinous cytoplasm. On higher magnification, you can see the intracytoplasmic mucin, columnar appearing cells, basal nuclei. So this is adenocarcinoma with mucinous features. That's my top line on biopsy. Again, this patient had bilateral lung nodules on CT chest imaging, and patient had a previous history of pancreatic cancer. And the tumor cells were positive for CK7, CDX2, negative for CK20 and TTF1. And we compared it to the previous pancreatic FNA cell block specimen, and the features of this was similar to the adenocarcinoma, what we saw in the cell block. So that helped us in the sense that we were able to tell that it's a metastatic lung adenocarcinoma, metastatic adenocarcinoma of pancreatic origin to the lung. Again, if we don't have the history with this immunohistochemical profile, while CK7 and CDX2 is positive, while TTF1 is negative, we cannot exclude a lung primary because 15% of the lung adenocarcinomas are TTF1 negative, especially the non-mucinous ones. The mucinous ones, they're mostly TTF1 negative. So you can't exclude a lung primary. And also because CK7 is positive, you can't exclude a upper GI primary as well. And in this case, CDX2 was positive. Again, that the GI primary cannot be completely excluded. So again, one more case where you compare the previous slides and you are able to tell, along with the CT imaging findings of multiple nodules in the lung, which again favors a metastatic process compared to a primary lung process. So as we were talking about mucinous adenocarcinomas, let me make this point. No immunohistochemistry will differentiate primary lung adenocarcinoma from metastatic adenocarcinoma, especially if they have mucinous features. Neither CK7 nor CK20 are specific for lung origin, and I am not using them to differentiate them. And many times what happens is you have a lung mucinous adenocarcinoma, or you have an adenocarcinoma with mucinous features on a needle core biopsy sample from the lung nodule, which is TTF1 negative. Now what do? So I generally put a comment saying that mucinous adenocarcinomas of the lung and upper GI, pancreatic biliary tract, they look similar. And correlation with imaging and PET staging to exclude those primaries from GI and pancreatic biliary tracts need to be done. before assigning a lung primary, something like that. So because histologically they look so similar and immunohistochemistry wise, you will not get much help. You need to combine various, you have to put the pieces of the puzzle together to make the final diagnosis. So many times you pick up the phone and call your surgeon, surgical colleague, or you call the oncologist to see what clinical or imaging findings would be present to help you in the diagnosis. So mucinous adenocarcinomas, remember that they are TTF1 negative in most occasions. Another needle core biopsy. Again, you see solid tumor cells, solid tumor nests of cells here, a lot of inflammatory cells in the background, but otherwise there's a lot of cytoplasm to these tumor cells. Higher power, you can make out some intercellular bridges and also some dense eosinophilic cytoplasm. Obviously, you must be thinking of squamous cell carcinoma. And it was squamous cell carcinoma, not just the morphology helped, but also CK56 and P63 stains were positive, supporting the diagnosis of squamous cell carcinoma. So the features sufficient for the diagnosis: keratin pulse, presence of intercellular bridges, and also the dense eosinophilic cytoplasm. In some non-keratinizing tumors where you need to do immunostains, because when you have a solid pattern of this non-small cell carcinoma, both adenocarcinoma and squamous cell carcinoma would be in the differential diagnosis. And you run your minimal immunohistochemical stain panel, P40 and TTF1. And like I mentioned to you before, in this case, the TTF1 was positive. But if you have P40 focally marking your cells, tumor cells, that means the criteria to consider something significant, especially P63, P40 positivity, is 50% of the cells. So if the staining should be at least more than 50% of the cells to consider them to be positive. So that's an important point. Otherwise, if you have some focal positivity, make sure you're not looking at basal cells which are entrapped in the biopsy specimen. So make sure they're tumor cells. There could be some non-specific staining in the background. It might be because of an artifactual kind of process, or it might be because of your immunohistochemical antibody itself, specific to your lab. So make sure you rule out those things before calling P40 positive and making a diagnosis of squamous cell carcinoma in those solid pattern exhibiting squamous cell carcinomas. The other question is differentiating primary origin of squamous cell carcinoma from metastatic squamous cell carcinoma. Again, many times it's not possible on histology alone. Some soft findings you can look for is, or if the overlying epithelium has got an in situ process like dysplasia or in situ carcinoma, and then you see the continuous process where it's becoming invasive, then you might think that it's the primary. The other subtle findings you can see if the patient has background lung with smoking related changes. Again, that's not completely true. Many times you can have smoking related changes in metastatic carcinomas too. So then how do you think that that would be helpful? May not be. But in situ carcinoma, dysplasia, then giving rise to invasive process, that's a good finding. That's a good supportive feature. But otherwise, you just have to look at the imaging and also the PET staging to see. But most important would be clinical history. So many times you would have done many stains and they're not helping you or they're not supporting you, and you have this case sitting in front of you like past 3 or 4 days, and you're thinking what might be the process, and then you call the surgeon and he says like, oh, by the way, patient had a history of Adenosquamous cell carcinoma. We don't have the slides. It was resected at the outside institution. So that itself would help you. So correlating with clinical history is always helpful. And a phone call to your surgeon is always helpful in these kind of scenarios. Another needle core biopsy. This one is more classic looking. No problems. It has features of squamous cell carcinoma such as dense eosinophilic cytoplasm, and also you can see some intercellular bridges and everything. So this one's a classic looking squamous cell carcinoma. And remember to do PD-L1 immunohistochemistry for squamous cell carcinomas. Well, adenocarcinomas, you got to do molecular testing as well along with the PD-L1 immunohistochemistry. Because metastatic lung cancers, the anti-PD-L1 therapy is indicated. So that's the reason we need to give the information on PD-L1 expression on both squamous cell and also adenocarcinomas of lung origin. So if the tumor, what you're looking at, doesn't have any morphologic features of small cell carcinoma, adenocarcinoma, or squamous cell carcinoma, and you have a negative IHC staining profile or ambiguous staining profile, then you just call it non-small cell carcinoma, but make sure you rule out a metastatic process. By looking at the clinical history, by looking at the patient records, that patient doesn't have any other cancers which might show these kind of features before assigning a non-small cell carcinoma diagnosis. And again, this is an important slide because whenever I see neuroendocrine morphology, like organoid nesting, rosettes, peripheral palisading, and the cells are big and large, with some of them have nuclear light, only then I do neuroendocrine markers. And if the neuroendocrine markers are positive, and then if you see this peripheral palisading, organoid nesting kind of pattern, then I would mention in the comment that this could possibly represent a large cell neuroendocrine carcinoma. In the top line, I would still say that non-small cell carcinoma with neuroendocrine differentiation. So something to remember, especially for this large cell neuroendocrine carcinoma cases. Again, final diagnosis is reserved in a resection specimen. So another example, left upper lobe mass, FNA and core needle biopsy in a 90-year-old man with idiopathic pulmonary fibrosis with a large lung mass. It's a good course. So you see tumor cells exhibiting different growth patterns. Here it's forming some nests of cells, but here it's in solid sheets. On higher magnification, they are forming smaller nests. And many of them has got this abundant kind of cytoplasm. Background has got this desmoplastic reaction, so obviously this is an invasive process. In the same core biopsy, you can also see some of the cells exhibiting the spindle cells morphology. And this location, you can see there is this attempt of forming some keratin, maybe like abortive keratin pulse, but otherwise you see some enlarged cells as well. So obviously there is some spindle cell differentiation. And we did P40, and P40 was positive in the small solid nests. But not all the spindle cells were marking P40. And the keratin stain followed the P40 reactivity. So the keratin was negative here in the spindle cells, but positive in all those areas where the P40 was positive. So we call this poorly differentiated squamous cell carcinoma with sarcomatoid features. Again, TTF1 was completely negative in this case. And this patient was a 90-year-old. He had several comorbidities, so they were giving him palliative radiation. But the point is about sarcomatoid features are spindle cell component. So any spindle cell, giant cell, or pleomorphic component on a small sample needs to be reported. You got to mention that. And also mention the associated epithelial component. If you have an adenocarcinoma or a squamous cell carcinoma component, which you, morphologically you can tell, and also immunohistochemically you can prove it, mention the associated component, epithelial component in the in the biopsy in the final diagnosis. And the final classification is reserved for resection. And as you know, the sarcomatous carcinoma cases has got bad prognosis for response to conventional chemotherapy. That's the reason you got to mention that in a small sample when you're putting the diagnosis on the comment. Again, there was a study by Dr. Moran and his colleagues from MD Anderson, 2017 article in Human Pathology, where they had an approach to non-small cell lung carcinomas with sarcomatoid elements. Again, more than 10% is needed to mention that sarcomatoid features in the final diagnostic line. Again, if you look at the WHO, the sarcomatoid carcinoma is a broad umbrella category where it includes spindle cell carcinomas, giant cell carcinoma, pleomorphic carcinoma. So all this comes under what is called a sarcomatoid carcinoma, and 10% of each of these components is sufficient to call them one of those. So what they said was, you can see tumors with conventional adenocarcinoma component. If the pneumocytic markers like TTF1, NAPSIN, they're positive, then you can call adenocarcinoma sarcomatoid type. If they're negative, de-differentiated. Same with conventional squamous cell carcinoma component. If those squamous markers like P40, P63 are positive, then you can call squamous cell carcinoma sarcomatoid type. If the squamous markers are negative, then you can call squamous cell carcinoma de-differentiated type. And in tumors where there's only sarcomatoid elements or larger looking cells, if one of these markers are positive, you can call respectively adeno or squamous sarcomatoid type. If they are negative, then it has to be classified as large cell carcinoma, which is like traditionally has been an ambivalent kind of category. So again, it was important to mention the type of epithelial component. That's the reason I'm trying to stress this with this article, that it's important to mention the epithelial component and then what type of sarcomatoid component you see. If it's a spindle cell only or giant cells or pleomorphic cells, so you got to mention that in the final diagnosis. Another example here, it's a cavitary lung mass in a 55-year-old man. This is a cell block specimen. You can see some darker looking cells. Again, darker looking cells with scant cytoplasm. You have two diagnoses, differential diagnosis, small cell and squamous cell carcinoma. So this tumor was P40 positive along with keratin negative for TTF1 and neuroendocrine markers. So we called it poorly differentiated carcinoma compatible with squamous cell carcinoma. Again, morphologically, you can see that it looked like small cell. You cannot completely exclude small cell, but it was also having some amount of cytoplasm. And some of the areas, there was also some apoptotic debris, like what you expect to see in small cell carcinoma. But that's the reason why whenever you see this basiloid kind of features or the cells with very hyperchromatic nuclei, which may resemble small cell carcinoma, always run a P63 or a P40. Again, I would prefer P40 because P40 is much more specific than P63 because P63 is shown to be positive in subset of small cell carcinoma. So if you have to choose between those two, I would choose P40 to make a distinction between small cell carcinoma and squamous cell carcinoma, especially in these kind of scenarios. Another example, 70-year-old woman with left lower lobe mass on CT chest. Patient had a history of COPD, chronic obstructive pulmonary disease. Again, nice needle core biopsy looking with a lot of tumor cells. They're forming solid sheets. There's a lot of tumor cells, some irregular sheets of cells. Higher power. Same cells, you can see them. The cytoplasm is on the scantier side. Some of them are exhibiting some molding, some overlapping of the nuclei. Background has got fibroelastotic kind of appearance. You can see these figgly little fibers. That's the elastotic fibers. So it might be a scar kind of background. There's some pigmented macrophages, not much of apoptotic debris in this figure, but I'm sure it was there in the rest of the biopsy specimen. And showing you the figure of pancytokeratin or A1, A3, you can see it has got a delicate dot-like staining, perinuclear in location. Some of the cells are also exhibiting stronger staining, but most of the cells exhibited perinuclear dot-like staining. So which, along with positive TTF1 and neuroendocrine markers, were supportive of small cell carcinoma. And also we did Ki67 on this, and it showed more than 80% proliferation rate. And also remember that TTF1 positivity can be seen in at least 85% of small cell carcinomas. So you have to remember that fewer cases of small cell carcinoma TTF1 is negative. And many times the neuroendocrine markers will also not support you. Sometimes, not many times. But if you have a perinuclear dot-like staining on keratin, and then you have some morphological features like hyperchromatic tumor cells, scant cytoplasm, nuclear overlapping molding, frequent mitosis, apoptotic debris, and necrosis, small cell carcinoma is a diagnosis. And many times if you have these histological features, you don't even have to do immunostain, but make sure it's a central mass and patient is a smoker. There's a single mass, usually they're big masses, hilar mass, encapsulating some surrounding structures. So clinical impression should be solid, and then microscopy, if you see these features of small cell carcinoma and H&E, that's all you need. You don't need any immunostains. But if any of this doesn't make sense, then you need immunohistochemical workup. That's when I do the immunohistochemical workup, complete workup. And many times the small biopsies, it's tricky that they have frequently exhibit crush artifact. And many times you need to do immunohistochemistry required to exclude the mimickers or the differential diagnosis. Something like lymphoma, they are keratin negative, CD45 positive. More important is neuroendocrine tumor, low-grade carcinoid tumor. So sometimes they're so hyperchromatic that you're not able to make out the salt and peppery chromatin or the neuroendocrine chromatin. So that's when you need to, I generally use a Ki67 when I have a smaller sample and we have a very small area of this neuroendocrine cells. So generally I've seen that Ki67 is less than 20%. It's supportive of carcinoid tumor, and they're usually stronger chromogranin than your small cell carcinoma. And if in doubt, I use what is called as 4-pack. So I use 4-pack, that is S100, SMA, smooth muscle actin, desmin, and keratin. So just especially whenever the cells look small, blue, round cells, that's when I use this 4-pack. So with this, you pretty much can, it gives a direction of which way you need to go, because S100 is positive in melanomas. I sometimes also add SOX10 instead of S100. Again, depends on what you have in your lab, you can use that. SMA, sarcomas, desmin for rhabdomyosarcoma. Again, keratin would tell you if it's a small cell carcinoma. And again, the other tumors, rarer tumors like Ewing sarcoma, CD99 positive. So those, depending on the scenario and the age group, you can think of those, excluding those entities. So immunohistochemistry pitfall in small cell carcinoma. So the keratin positivity, I give a lot of importance for keratin positivity in small cell carcinoma. And again, neuroendocrine markers, if they are negative, keratin positivity, definitely exclude non-epithelial tumors. But if the neuroendocrine markers are negative, I also do a P40, exclude that basiloid squamous cell carcinoma or poorly differentiated squamous cell carcinoma before making a diagnosis of small cell carcinoma. And again, you must remember that 10% of small cell carcinomas are neuroendocrine marker negative. That means your classic synaptophysin, chromogranin, and CD56. Those were the traditional markers we've been using since forever. But recently there was a new marker described, INSM1. This is a modern pathology article published by Sanjay Mukhopadhyay about INSM1. So that's a good read. If you want to bring this antibody, it has got a lot of promise, at least in the earlier studies. They've seen that it performs better when you compare to this combined 3-panel of neuroendocrine markers, that is synaptochromo and CD56. Another example, right upper lobe lung mass, patient with a history of squamous cell carcinoma. This one is peculiar looking because it has this chondrite kind of look to it and some bone here, and there are spindle cells. And again, on higher power, you can see the spindle cell morphology of the tumor cells. And also you can see the cartilaginous area of the chondrite kind of areas, and then osteoid, possible osteoid with calcification, and then the spindly kind of cells which are around this osteoid kind of formation. So obviously osteosarcoma, the soft tissue sarcomas are in the differential diagnosis. So spindle cell proliferation. So we said sarcomatoid appearing spindle cell population in a background of atypical chondrite and bone. So multiple keratins, cytokeratin A1, A3, which is a pan-cytokeratin, CAM5.2, high molecular weight cytokeratin, CK7, CK20, they were all negative. And we also have this multiplex stains in our lab where we have PTF1 and napsin as one stain so that we can save tissue. And then lung squamous, that is P63 and CK56 as one. We just need one slide section to run those. They were all negative. They were all negative in this case. So obviously the differential diagnosis would be, can it be sarcomatoid carcinoma or is it carcinosarcoma? Because you have both, if that spindly component is carcinoma and then you have the soft tissue component, mesenchymal component. So carcinosarcoma is also in the differential diagnosis. Or sarcomatoid mesothelioma or soft tissue sarcoma. So all these would be differential diagnosis. Again, are we missing anything? Or are we missing any kind of history in this patient? So then we dig up the history and then patient has a past history of Adenosquamous cell carcinoma with sarcomatoid features. And patient had a lung resection earlier before this needle core biopsy, which showed sarcomatoid carcinoma with prominent areas of atypical heterologous chondrite and osteoid formation. And then we compared this specimen and we looked at the slides of that lung resection and they were similar. So the final diagnosis was metastatic sarcomatoid carcinoma. So again, I was trying to emphasize the point that there's nothing better than looking for if the patient has any previous history of cancer, any other sites of cancer, and also important would be comparing the slides, gold standard. Morphological comparison, it's still the gold standard. It's a old way of doing it, but still it holds good. Any scenario, any cutting edge technology, you might have to figure things out, but that's a classic old way of doing things. You compare the slides to the previous ones, and knowing that the patient had something in the past always is helpful. Another example, left lower lobe lung nodule, 83-year-old male with a history of non-Hodgkin's lymphoma. Again, you see some elongated kind of cells in fascicular kind of growth pattern on higher image, very scant amount of cytoplasm, elongated spindle cells. So several differential diagnoses. So obviously lung mass, you got to exclude a sarcomatoid carcinoma or a spindle cell carcinoma. Mesotheliomas, if they're around the pleura kind of region, lower lobes are closer to the pleura. Synovial sarcoma can happen in lung, although it happens more common in extremities. Solitary fibrous tumor, Ewing sarcoma, pleuropulmonary blastoma, again age, and pleuropulmonary blastoma, you usually have a biphasic kind of appearance. Here it's all spindly cells. So in synovial sarcoma, you're thinking of monophasic. Again, this might not be the complete representative of the entire tumor mass. So all these were in differential diagnosis. But in this case, we did run a broad immunohistochemical panel. The EMV was focally positive. The broader keratins were negative. CD99 was weak. BCL2 was strongly positive. So obviously the synovial sarcoma was top of the list. Solitary fibrous tumor, the STAT6, those were negative. Since it was a smaller biopsy, we were not able to tell that classic stag-on kind of architecture of blood vessels, what you see in synovial sarcoma. So in these cases, definitely we need more additional workup. So we send this paraffin block for FISH and confirm the presence of SS18 rearrangement, which is supportive of synovial sarcoma in this case. And again, looking back at the history on this patient had a history of monophasic synovial sarcoma of the lung 7 years ago. So that was useful. And again, this translocation, diagnostic translocation, what you have seen before or heard before, X18, it's definitely useful for a differential diagnosis, and it's mostly seen in 90% of synovial sarcoma. So that's how we figured this case out. Another biopsy, right lower lobe lung biopsy, patient had a history of squamous cell carcinoma of scalp. Also, patient had a history of thyroid carcinoma, no details on the histological type. So this is what we had, smaller core biopsy samples, but there were some tumor cells here, so obviously positive for malignancy. On higher power, so you can see desmoplastic reaction in the background. Cells with some cytoplasm, not a whole lot of it, but doesn't form any glandular kind of growth pattern. It's more in the sheets. So we traditionally run these markers. So these were positive or squamous markers, P63 and CK56, negative for TTF1, NAPS and CDX2. Again, we also did, since the patient history of thyroid carcinoma was there, we also did thyroglobulin and Paxate. The Paxate was strongly positive, nuclear positive in these tumor cells. So we called it metastatic anaplastic thyroid carcinoma with squamous features. The thyroglobulin, the point about thyroglobulin is they can be negative in at least 20% of your anaplastic thyroid carcinoma cases. They're more positive in differentiated thyroid carcinomas. Again, that's the point you need to remember. And here in this case, the Paxate was important here because Paxate not only tells you that it could be origins from any of the sites like kidney, ovary, thyroid, pelvis, retroperineum, that's the GYN tract, and also thyroid. So this paper from Dr. Sanjay Mukhopadhyay again looked at Paxate positivity in 418 cases, and they reviewed the literature, and they said the question they were answering was, is Paxate positivity seen in primary lung carcinomas? That's the question they were answering. So in their study of 418 cases, they saw Paxate was weak or moderately positive only in the focal areas, focal tumor cell areas. And they saw in 5 large cell neuroendocrine carcinomas. So none of the other lung cancers like adenocarcinoma, squamous cell carcinomas, the traditional ones were Paxate positive. So they said that the stronger Paxate staining, it's encountered in metastasis from non-pulmonary sites. The number one is kidney, followed by GYN tract, thyroid, these areas. So that's what you can see that example in the case which I shared, the metastatic anaplastic thyroid carcinoma with squamous features. Another example, right lower lobe needle core biopsy in a 62-year-old gentleman. So there was an irregularly marginated nodule at the lung base. CT was concerning for an inflammatory infectious process. Patient had a follicular lymphoma status post-chemotherapy. Good adequate ovulated lung parenchyma, good course with some blood vessel walls here. Higher power, you can see this areas, fibromyxoid kind of areas, fibromyxoid plugs. And then you have this ovulated lung parenchyma. Some other areas we also saw airspace fibrin. Again, the pneumocytes are not that reactive, but they're prominent. They're prominent. So because of the presence of fibromyxed flux, we call this organizing pneumonia. And we said in the comment that this could well represent an inflammatory process. And also sampling at the edge of the lesion might also be reason for seeing only focal organizing pneumonia. So this was one of those negative biopsies, but the clinical impression was also inflammatory/infectious. So this case was interesting. 17-year-old male with a history of malignant neoplasm of the tongue. Now they're doing a left lower lobe lung needle core biopsy. So the question is, what's going on in the tongue? Can it be metastatic? Can it be a primary tumor in a 17-year-old? So that's what we're trying to answer here. So you can see the ovulated lung parenchyma fragments. There are enough ovulated lung parenchyma fragments, so that's a good biopsy. Prominent reactive pneumocytes lining these alveolar spaces. There's some hemocydin-laden macrophages. The smoker's pigment is much more finer and yellow, and they will have some admixed black pigment. This one is a little more chunkier, so hemocydin. Some areas there was some structures like this, but otherwise reactive pneumocytes, some of them are prominent here. So hemocydin-laden macrophages, same thing on a higher magnification. So it was a negative biopsy. We saw reactive pneumocytes, again, pigmented macrophages with hemocydin kind of pigment. So there might have been some organized hemorrhage before in this location, but we did not find any malignant cells. So then the history on this patient was patient had a tongue epithelial sarcoma. That was the history. So obviously we did not find that in the needle core biopsy. So they went ahead and did a wedge resection to rule out a metastatic sarcoma in this case. So you can see a lot of fresh blood here, inflammation consisting of lymphocytes around the peribronchial or peribronchovascular regions, some expansion of the interstitial septa, otherwise prominent reactive pneumocytes lining them. Fresh blood, some areas you saw this, we saw this hemocydin-laden macrophages, some expansion, what could be organizing pneumonia kind of areas. Same thing here, same those kind of organizing pneumonia kind of areas, and then this hemocydin-laden pigment. But the TTF1 was highlighting all those reactive pneumocytes. There was no area where abnormal cells or atypical cells were seen, or the plumpy epithelial cells were seen. And to support that, the INI also showed intact staining. And so obviously this lung resection did not show any residual epithelial sarcoma. It was just showing some organizing process. But a concurrent brain specimen showed metastatic epithelial sarcoma. So you got to remember that benign reactive processes always in the differential diagnosis for a neoplastic lesion. So you might expect to see that in needle core biopsies. So let me summarize. So the time is 9:56, so I might need 10 more minutes after this. So the terminologies for small biopsies, so this is from the surgical pathology clinics. Nice chapter, you can read that. If you have morphological small cell carcinoma pattern with positive cytokeratin markers, you can make a diagnosis of small cell carcinoma on a biopsy. Whereas if you have a morphologic adenocarcinoma patterns, that means the glandular differentiation, mucin vacuole or intracytoplasmic mucin vacuole, then you can make a diagnosis of adenocarcinoma. And if TTF1 napsin is positive, then lung origin. If you don't see those patterns, pattern of adenocarcinoma, but the tumor is positive by TTF1, then you say non-small cell carcinoma favor adenocarcinoma of lung origin. Similarly, if you see morphological squamous cell carcinoma patterns, you call squamous cell carcinoma straight away. But if it's poorly differentiated, solid growth pattern, You don't see keratin pearls. You don't see intercellular bridges. You are not seeing the dense eosinophilic cytoplasm. But the tumor cells were P63, P40 positive, then you still say non-small cell carcinoma favored squamous cell carcinoma in the small biopsy. In this category, no clear adenocarcinoma, squamous, or neuroendocrine morphology staining pattern you call non-small cell carcinoma, NOS, not otherwise specified. So that's the terminology the WHO recommends to be used in the small biopsies. Again, the last few slides I'm going to discuss about molecular testing. So this one is hot out of the press. Journal of Thoracic Oncology 2020, I think last week, I think last month. So International Association for the Study of Lung Cancer. So they sent a survey out, international survey on implementation of molecular testing in lung cancer. A total of 2,537 respondents from 102 countries responded to this, and they said less than 50% of patients in their country receive molecular testing for lung cancer. And they recognize 5 most common barriers: cost, quality and standards, access, awareness, turnaround time. Again, I would refer you to this article to understand the details of these barriers in different regions of the world. Again, they also recognize that most of these respondents were from Asia. And the interesting part was up to 33% of the respondents said that they're unaware of the guidelines, what CAP, International Association of Society of Lung Cancer, and Association of Molecular Pathology guidelines were. So they were not aware of these guidelines. That's why I got this 2013 article, which all started with these guidelines, the same CAP, IASLC, and then AMP. So 2013, they come up with the guidelines, say that all lung cancers should be tested for EGFR and ALK to determine the eligibility for tyrosine kinase inhibitors. And then in 2018, so this is a 2018 archives article, updated. So they came up with molecular testing guideline, updated guidelines, same groups. So they have this summary statement. They compared 2013 to 2018. So they said cytologic samples are suitable for testing. Cell blocks can be used. Cytologic preparations can be used. They also said in 2013, they said that EGFR test methods able to detect mutations in specimens with at least 50% cancer cell content. But they encourage laboratories to use more sensitive tests to detect mutations in specimen as little as 10% of cancer cells, which they increased to 20% in the 2018 statement. So if you have 20% cancer cells, then whatever molecular testing assay is there, it should be able to detect it. So you got to make sure that you use those kind of assays. So that's the point about that. There was a strong recommendation in 2013, then 2018, that immunohistochemistry is not recommended for EGFR testing. Same thing holds good here, 2016, and for all purposes. So EGFR always should be part of your NGS panel or PCR technology. It never be tested by using immunohistochemistry. And along with that, what I showed you in 2018, they also had other additions to that recommendation, like ROS1 testing should be done in all adenocarcinoma patients. And immunohistochemistry can be used as an alternative to FISH for ALK and or ROS1 testing. We have immunohistochemical antibody clone D5F3 clone for ALK, but we don't have immunohistochemical stain for ROS1. We use the FISH. We were using FISH until the new panel where it takes care of that too. And then they also said inclusion of additional genes, especially in labs which are using next generation sequencing panels. So the additional genes are ERBB2, that's nothing but the HER2, MET, BRAF, KRAS, RET. So EGFR, ALK, ROS, and these genes. So if your lab has got an NGS panel which includes all these genes, then you're covering this updated recommendations as per 2018. And then EGFR T790M mutations, which is the reason for resistance to EGFR inhibitors. So they recommended that 5% sensitivity, that means you should have a sensitive assay to detect this EGFR 790M mutations, which can further determine the eligibility for third generation tyrosine kinase inhibitors, especially osimertinib, which is what they use for this. And also they mentioned use of cell-free DNA liquid biopsy to rule in targetable mutations when tissue is limited or hard to obtain. It could be because of so many reasons. And again, whenever the tissue is available, the tissue biopsy is always preferable for liquid biopsy because of variability in the sensitivities and the specificities of these available assays. Always the tissue is always better than liquid biopsy. So those were the updated recommendations in 2018. So recently there was this big CAP laboratory improvement program study. So CAP, they convened expert panel and they reviewed, you can see enormous number of studies, 4 to 5, 6 studies. Out of that many studies, they determined 218 was meeting their inclusion criteria, which formed an evidentiary base for the 16 guideline statements. So they developed the 16 guideline statements. I would refer you to this article, which is an open access article in the Archives journal, and it came out recently. And this was basically done to assist clinicians and pathologists in collecting and processing thoracic small biopsy and cytology tissue samples. Again, there were 3 strong recommendations which I want to tell you. EBUS TBNA, transbronchial needle aspiration for initial evaluation, and ROSE, rapid onset cytologic evaluation, should be done for adequacy of tumor cells, if you got enough tumor cells or not. And then cytology specimen smears, cell blocks, liquid-based cytology is used for ancillary studies. Actually, the smears are actually one of the best DNA material you could get, unlike the paraffin sections where they're usually the processing artifact would be there. But the smears give you the best DNA material for your next generation sequencing panel. That's what we use in our institution also. So NGS panels are the next generation sequencing panels, which can include all these different genes and fusion partners. They can increase the utilization, means they can help the physicians in selecting therapies, especially with this new age where there's rapid development of various additional targeted agents. Also, they also mentioned that FDA recently had a targeted therapy approval for BRAF and NTRK rearrangements. So already you can think that 2018 guidelines are already in need of revision. So things are rapidly changing, and the lung cancer scenario is very exciting because there's always some new things coming out, FDA approvals coming out, new drugs available. So it's an exciting field if somebody you are thinking of getting into this field. I think those are my references. So before concluding, let me thank the KCIAPM and Aditya, and also hopefully you can relate with me that the needle core biopsies of the lung, sometimes they have multiple different directions. They're challenging, but if the right clinical context and with the right usage of the immunohistochemical analysis and also morphology, your morphology is still the king. Your H&E is the best molecular stain you can ever get. So remember that, and then hopefully my presentation would help you in dealing with those challenges. And let's see if we can take some questions.
Yes, thank you for that extremely informative lecture with a lot of practical pearls, which will actually help us in our day-to-day practice. So we'll take a few. We do have a lot of questions coming in from YouTube. We'll be taking those. The first question is by Dr. Archana Bhatt, and she wants to know how to differentiate between regenerating pneumocytes from the lipidic pattern.
Yeah, it's a good question. So the lipidic growth pattern, obviously you don't have the gaps in between the cells, and sometimes you have to look at the imaging, because there's a mass lesion growing in the CT scan, and so clinically they're expecting a lung mass and that scenario, but reactive pneumocytes, sometimes it's so hard to differentiate. You just have to put everything into perspective. If you have reactive pneumocytes with acute lung injury pattern, then you're obviously thinking non-neoplastic reactive process. But if the biopsy looks clean, no acute lung injury, no fibrin, no interstitial expansion with fibroblastic tissue, then you still have architecture of the alveolar spaces, but lining of those tumor cells with no gaps in between, then you're thinking of lipidic growth pattern. But it's a real challenge every single day. But you have to put everything into perspective to differentiate. But good question.
Next, Dr. Swati, you would like to take that?
Yeah, next question is by Dr. Abu Arshad. Why can't a double positive, like for example, if the tumor is positive for TTF1 and napsin A, differentiate a primary lung carcinoma, adenocarcinoma from secondary? Adenocarcinoma.
Oh yeah. TTF1 and napsin A positive, yeah, that definitely tells you it's primary lung carcinoma, primary lung adenocarcinoma. Sometimes you might not do napsin, just TTF1. Again, you have to remember the different clones of TTF1 when you're using it in your immunohistochemistry. Again, there are 3 different clones of TTF1. SPT24, which is the most sensitive clone, while 8G, 6G, 3/1 is the most specific clone. So it depends which clone you're using, because many times we have seen that the sensitive clones like SPT24 are positive in non-lung adenocarcinomas. So in that scenario, your napsin would help you. But also you need to look at what type of TTF1 clone you are running in your lab. So you have to put those things together before you're assigning a primary or metastatic process. But otherwise, if the lung mass lesion is TTF1 napsin positive, I would call it lung primary.
I think that also answered Dr. Swati's question as to which ones to prefer, if whether TTF1 or napsin for primary adenocarcinoma.
TTF1. I would pick TTF1.
All right. So Dr. Jayalakshmi wants to know, in the small biopsy, the morphology is very specific of each. Then can't we give a specific diagnosis instead of non-small cell carcinoma?
So again, like I explained, if you have morphological features, you can give specific diagnosis. Nobody's stopping you. So if you have glandular pattern, if you have mucin vacuoles, you have the specific features, go ahead and give the specific diagnosis. But if you don't have the specific morphological pattern, you have a poorly differentiated tumor, then it could be several differential diagnoses. In that scenario, you tend to do immunohistochemical stains, and if they're helpful, you can favor one over the other. If TTF1 is positive in a solid carcinoma, then you would favor adenocarcinoma, and if P40 is positive, you favor a squamous cell carcinoma. So it depends on the scenario, what you're seeing morphological features. As long as possible, if specific features are present, I would definitely encourage giving a specific diagnosis.
Right. Thank you. Dr. Swati?
Sir, I myself had a question, sir. So did you, were you able to categorize all the subtype, all the cases? Like, for example, some cases we couldn't subtype at all. It just goes as polydifferentiated carcinoma. The tumor was just positive for cytokeratin and absolutely negative for rest of the marker. So have you encountered such cases, and what do you do about next? What do you tell the clinicians in that case?
So we just call those cases as poorly differentiated non-small cell carcinoma because morphologically they're not supportive of any specific type, and immunohistochemical stains, they're negative. But we try to minimize the number of stains we use it. As far as it's not a metastatic process, we try to minimize it and use it. The next step would be to do the molecular testing. And again, if there is a suggestion of adenocarcinoma, we'll definitely do molecular testing. And in all those cases, we do molecular testing to see for any mutations. And if you have a mutation which you see in adenocarcinoma, something like EGFR or ALK, then that's going to be useful for the clinician more than you're categorizing the entities, because at the end of the day, what is more important for the patient is if the patient gets treated for the tumor for which they come to you. So we see those cases very often, and we rely on molecular testing in those cases. And generally, we call them as poorly differentiated non-small cell carcinoma (NOS), and we tell the same thing for our clinical colleagues. And the patient has a lung mass, then it's the chance that it's lung primary. That's how we deal with it. But we try to do molecular testing on PD-L1 on all adenocarcinoma cases, while on morphologically identifiable squamous cell carcinoma cases, we only do PD-L1 testing, not molecular testing.
Dr. Zulekha Patel wants to know what's the adequacy for a small lung biopsy?
As long as you can make a diagnosis, that's adequate. There is no set criteria or anything like that for adequacy. But you need 20% of the tumor cells for molecular testing. So probably I will tell you that. In terms of final testing, I'll tell you that 20% of the tumor cells need to be there. So for me to do molecular testing, so if I can get the diagnosis, but I don't have enough cells, for further testing, I would mention that in the comments, saying that I don't have enough material for further molecular testing, which is an important thing in the present day for patients to start thinking about targeted therapy. But there is no number. As long as you can make a diagnosis, it's adequate. And sometimes you can't make a diagnosis. A reactive process, you can't differentiate from a neoplastic process. You tell the same thing. You see some atypical glands, but you're not sure if it's reactive or malignant. You tell that in the comments, saying that the material is too small for me to make a distinction between reactive versus malignant process, and repeat biopsy is recommended.
All right. Thank you. Dr. Swati, do you have anything else?
There's one question here, by Dr. Parveen, how do we differentiate poorly differentiated carcinoma from anaplastic lymphomas?
Anaplastic lymphomas, anaplastic large cell lymphomas. Yeah, many of those are ALK positive, but they're also keratin positive. So it's always a good scenario to, it's a challenging scenario. But your traditional markers are negative for carcinoma like PTF1, P40. But in these cases, obviously, you take your help of your hematopathology colleagues. I'm not a hematopathologist, but I would use CD30 whenever I'm thinking of that. CD30 is a good marker. ALK may not be positive in all the cases. There are ALK negative anaplastic large cell lymphoma cases too. So it's a real problem, but I would definitely show it around, show to my hematopathology colleagues. For CD30 and ALK are the two stains. If they are positive, it helps me, along with other negative stains for traditional lung adeno or squamous. That's how I deal with those cases. But good question.
So Dr. Zulekha Patel wants to know how to differentiate between poorly and moderately differentiated non-small cell carcinomas, non-small cell squamous cell carcinomas.
It's not required. You don't have to worry about the differentiation. The differentiation, finally, you can do that in resection specimen. But whenever you see intercellular bridges, it's moderately for me. Whenever you see keratin pulses well differentiated, you're not able to see those, then it's poorly differentiated. That's how I go about those differentiating as far as the differentiation of squamous cell carcinoma is concerned.
All right, so thanks a lot. We don't have any more questions. I think you can stop the sharing the presentation and make the closing remarks for us.
Sure.
Thank you so much, sir. It was a brilliant talk.
Glad
we
you
learned a lot today.
Glad you liked it.
Yeah, I think I'm talking on behalf of all the viewers.
You know how many people attended?
Yeah, 300 plus live audience, and it will increase soon. And so we have a closing remarks from you before we close the session.
So yeah, thank you again for your invitation, and thank you for the opportunity. It's always challenging to diagnose this stuff in small biopsies, and I think, like, you can agree with me that all of us have these challenges every single day in our practice. Because lung cancer is one of the deadliest cancers. Like I mentioned, the survival rate is only second to pancreatic cancer. So obviously, the anxiety when you tell to a patient that you have lung cancer, it's not just the patient; the entire family is under stress. So in that perspective, if at the same time, if you tell the patient that you have hope because you have a mutation which is targetable and we have a drug for that. For example, I remember the story. There was a young woman. She had small little kids and she never smoked in her life, but she comes back with lung mass. And then she gets a biopsy and she had a lung cancer. And you can imagine how she might have felt, like small little kids, and then her whole world collapses in front of her. But the interesting part was her lung cancer was ALK positive. So there was an ALK rearrangement, and she had a specific, she received tyrosine kinase inhibitor, crizotinib. And after a few months, her lung cancer cleared. And she could go back to her life. She got a second rebirth or something like that. So it's so important for us as pathologists to not only do our best in, obviously we do our best in diagnosing these entities, but also make sure we can do all what we can in identifying if there's anything targetable. And then give that option or the opportunity to the patient for them to get complete cure of their cancer. So that's what I can tell you. And again, thank you for your time. And I appreciate all the viewership and all the questions. And also you too specifically, because you had made time in a busy schedule in spite of the COVID challenges you guys are having. All of us are having the same thing. And also, I must congratulate KCIAPM for all the brilliant social media activities and educational stuff they're doing online, also in real person.
Thanks a lot for those kind words, sir. And it was an extremely eloquent and lucid presentation that we had today with beautiful slides that you showed us. I think we all have learned a lot of take-home messages that we can implement in our day-to-day practice and to help give a better care, a better diagnosis for our patients. We have learned a lot today, and we thank you for that. Thank you, sir.
Oh, wonderful. Wonderful. Thank you.
All right. Well, thank you. With this, we will be closing the session. Thank you all, the audience, for joining us. We will be coming live again next Saturday with a panel discussion on quality in control and pathology. Do join us for that. Thank you.